Hi, this is F.Hafezi from the ELSA Institute in Zurich, Switzerland. Today's topic will be corneal cross-linking at the slit lamp. And these are my financial interests. Now, corneal cross-linking has come a long way in the past 20 years to become what we know nowadays as a global standard of care, developed in Zurich with approximately 200,000 procedures and more than 2,000 scientific publications known in Medline. This is a historical image. This is the very first cross-linking device that we built at the time, and again historical, one of the very first epi-off procedures filmed, as you can see here, using the old riboflavin with dextrane, the viscous one. Ever since, we've learned so much about how modern cross-linking works, and we know nowadays that we need three different elements, which are UVA, riboflavin, but also oxygen, and oxygen is the determinant. You always need enough oxygen in the cornea at any moment of your cross-linking reaction, and so everything else has to evolve around oxygen availability. It took us more than a decade and more than 100 papers published from our group to better understand how to play with all these factors, which are how fast do we cross-link, how much intensity do we use, and if you multiply intensity times time, you get the total energy, which is the fluence. Shall we pulse the light, yes or no? And by putting all these pieces of the puzzle together, we were able to become more and more efficient while saving time at the same time, and even going transepithelial. And this quest took more than 12 years from the first concept in 2009 to successful epi-on cross-linking in 2021. And you may have heard about it. You can give a boost of oxygen over the corneal surface, and this was 2 years ago. And by doing so, you already can have successful epi-on, but you need additional technology. Our aim was to get to functional epi-on without the oxygen boost, and it was our friend Cosimo Mazzotta from Italy who has shown that you can perform epi-on without additional oxygen by intelligently combining these factors, which means no oxygen boost but pulsed light in a relatively slow acceleration, so not 3 or 4 minutes but rather 10 to 12, using high fluence. And Mazzotta still needed to use iontophoresis to push the riboflavin into the cornea. The exciting thing now is he published data on this with a 3-year clinical follow-up, and this works nicely and efficiently. And what we have done lately, we have omitted the iontophoresis step also. So what we have started doing now at the ELSA Institute is epi-on cross-linking without additional oxygen, without iontophoresis. This is what makes me so exciting, because in conclusion, if we look at where we stand with epi-on in 2021, I use it in all my adult cases now that are not aggressive. So the only times I go back to epi-off now is in children and in ectasia after LASIK, or if I have a very, very strange hormonal state like massive hypothyroidism or an ovarian cancer and so on. So epi-on for now is working, and it is working because we understood how essential oxygen is and how to manipulate the oxygen content in the cornea. And you can do this without oxygen boost, even without iontophoresis, which opens alleys for an epi-on, even a bilateral epi-on procedure at the slit lamp. So that's the first topic. The next topic is PAC cross-linking. So cross-linking for infectious keratitis. And what is the most important element to maintain here, keep in mind that in performing cross-linking, you do not only stiffen the cornea, you do much more. You increase resistance to digestion, and you kill by these two mechanisms, which means that cross-linking, every cross-linking reaction does all 4 things at the same time. If you cross-link your cornea for keratoconus, you do not only stiffen, you sterilize that cornea. And if you do a PAC cross-linking for keratitis, it's just a different term, but the technique is the same. Then you also stiffen the cornea, but you don't really need this, right? You want to kill. So you use the other mechanisms. We learned that infectious keratitis, in contrast to cross-linking for keratoconus, is a very different ball game in terms of numbers globally. We speak about 6 to 8 million new cases per year, and we speak about the big dilemma we have in many instances where the patient comes in with an ulcer. And if you have 20 years of experience in cornea, you can detect most cases and classify them correctly. And this is bacterial, this is rather fungal, and this is probably mixed, and so on. But if you have 3 to 5 years of experience, it becomes increasingly difficult. So the challenge in infectious keratitis treatment is the right diagnosis that translates into the right treatment, or worse, the wrong diagnosis translates to the wrong treatment that can be deleterious to your cornea. The beauty of PAC cross-linking is it kills bacteria and fungi at the same time, which makes it much more independent from the observer's experience. And in developed countries, most of the cases are contact lens wearing related. Contact lenses per se are extremely safe, but we know about the patient's compliance, which sometimes is suboptimal. And in LMIC, countries with low to middle income, we often see workers in the field that have a minor scratch on the cornea and then protracted treatment. We defined the term PAC cross-linking back in 2012. I defined it together with Brad Wendelman at the Cross-Linking Congress. This was a joint decision to call it PAC cross-linking. And a few years before already, our group in Zurich published the very first case series that started this type of application. And where are we standing now? As you can see, PAC cross-linking works even in advanced cases. It can kill at the same time, irrespectively of antibiotic resistance. So what we learned to do over the years is accelerate the treatment from 30 minutes, which was the original Dresden protocol, to 4 minutes. So PAC cross-linking is not as dependent on oxygen as cross-linking for keratoconus. You can go much faster, and by increasing the total energy almost 3 times, from 5 to 15, we are able to treat even advanced fungal keratitis. So there's much more to come in PAC cross-linking in terms of increased fluence and accelerated treatments. We published a cornea paper last year showing that the higher you go with the fluence, up to 15 joule, the more efficient you get. So in conclusion, for PAC cross-linking, the results of our multi-centered trial that I have not shown here now for time's sake showed that in ulcers of mixed or bacterial or fungal origin up to 4 millimeters, we are just as good as antimicrobial therapy. So I use PAC cross-linking in every ulcer that comes through my door. And of course, I still give antibiotics or antimicrobials, but by doing a simultaneous PAC cross-linking procedure using riboflavin, I ensure that the cornea is more resistant to digestion, and I kill a lot of microorganisms. I accelerate healing. We also published on this 2 years ago. And as I said, next step, we will increase efficacy by going higher and higher in fluence. So as you can see, we have modern epi-on treatments in cross-linking. We have highly accelerated PAC cross-linking treatments. So this opened up the alley to fulfill our dream and our vision, which is to go out of this very costly and big infrastructure to the one infrastructure we all share as eye doctors, which is the slit lamp. Let's look into this. Cross-linking at the slit lamp. Why does it make sense? Take a country that has very divergent regions like India. You have megalopolis that are very modern, and then you have remote areas with a low infrastructure medically. So having a cross-linking approach at the slit lamp would mean to serve remote areas. It would mean you can treat much earlier because you bring the technology to the people and not the opposite. You increase coverage. We call it democratizing cross-linking. And even in countries like the US, an office-based approach will heavily reduce costs. And we hear more about this in a second. And also, you can separate your infectious cases from your cataract surgery list in the OR, which certainly is a very, very good idea. Now let's look into cross-linking at the slit lamp. This is the CI device that I helped develop in the past 8 years. It can be used at the slit lamp, but also traditionally, we call it the classic way, in the lying position, providing pulsed light, continuous light, 3, 9, 18, 30, and also 50 milliwatt for some applications, epi-off, epi-on or puck cross-linking. Now, let's play devil's advocate for a moment and say, okay, this is nice, but cross-linking at the slit lamp, we've been doing this in the lying position for a reason. Can this really work? Now, let's look at the questions of a skeptical. One question could be, what happens to riboflavin when the patient sits? Doesn't it go down with gravity? It does, but it takes 1 hour. We published on this. So in cross-linking at the slit lamp, we apply the riboflavin in a reclining chair, and then the patient comes to the slit lamp, and from that moment on, you have 1 hour of time before you can measure a gravity gradient. And we don't need 1 hour in irradiation, right? So this has been solved and published. The next question many pose is fixation. Look at the lower video. The only reason I can tell you it's a video is because I see this flickering of the screen. The patient is absolutely fixed in targeting, and what helps tremendously is the red fixation light that you could use for examination of the retina or gonioscopy. And by providing the fixation light to the other eye, the patient has a clear target they can fixate. So this works very nicely. You do not need an eye tracker for these applications. Third element I hear very often is, isn't it uncomfortable, half an hour at the slit lamp? Please remember, it's not half an hour anymore. It is roughly 10 minutes for the successful epi-off applications, and it's only 4 minutes in puck cross-linking. You can easily do 4 minutes, and as you can see, that's just a small trick. We give the surgeon's chair to our patients, so they sit really comfortably with the armrest. The last element is the most important. When I tell my colleagues that I'm performing cross-linking in an office-based surrounding, then the first question they ask me is not one of these. The first question they ask is, what about infection? Aren't you worried about infection? Let's look at this. Let's say CXL for keratoconus. You have a keratoconus treatment. Why can't you do it at the slit lamp in your doctor's office? The reasons you can are the following. Remember, I showed you all these effects. So with every CXL procedure, you make the cornea sterile in the end. So at the end of CXL epi-off, the cornea is sterile. Then take care of this cornea. But as I told you, we will soon switch to epi-on, and then you have no issue at all. And the second thing is, have you seen these papers lately showing that you can perform cataract surgery office-based, you can perform injections, intravitreal injections office-based, cohort studies with 21,000 eyes for cataract, 11,000 eyes for injections, no increased risk of endophthalmitis. So if we can perform this type of surgery office-based, we certainly can perform cross-linking. And again, once we are in epi-on mode, there is no more risk for infection at all. And what about puck cross-linking for infectious keratitis? Well, these patients are infectious already, so there's no question about that. You are trying to reduce the infectious state. If you want to have some more insights, please visit the Journal of Refractive Surgery. We have published the technique early in the year. And this is what you can see when you look through the slit lamp, because this is the only technology that allows you to directly monitor what is happening. And what is nice is that the word is spreading. We had a very nice feedback from Boris Kneiser from Israel telling us that he loves doing this in his wheelchair patients because it makes the whole procedure easier, especially with restricted mobility. So in conclusion, CXL at the slit lamp democratizes access to cross-linking technology. It is suitable for all indications, epi-off, epi-on, puck cross-linking, also for extra procedures in refractive surgery. And I clearly believe that CXL, especially in the case of keratoconus treatment, bilateral epi-on cross-linking is the future of cross-linking. Thank you for your attention.